Hi everybody. Today we'll discuss a breast limp, how to approach, what is the clinical aspects. I will be asking the questions during the session and you can type in the chat box. This is a live interactive session. Okay. Now, a 20 years unmarried female present with a complaint of lump in the right breast, 3 years duration. You can see the lump here, a vague lump. In the right breast, 3 years duration, unmarried girl, age 20 years. Coming to the history of present illness. Now, what are the things you ask when a lady present with a lump? Now types. What are the questions you want to ask? I told you chief complaint and also duration. Now, in the history of present illness, what you would like to inquire? This is a virtual clinics. A similar case is kept in the examination. Patient tells the duration, I already told you, duration is 3 years. 20 years age, unmarried, female, 3 years duration. Good. Second, somebody said pain. Okay, pain is present or not. Now, in the case of pain, that is called mastalgia, that is breast pain, this is a very common symptom. And more than 50% have psychological component. Second thing is when pain is present, you have to ask whether it is cyclical or non-cyclical. Cyclical means pain occurs at a particular period in every menstrual cycle. That is called cyclic. Non-cyclical means at any time of the cycle, pain may present. When they complain of pain, you ask whether it is cyclical or non-cyclical. Now, the difference is clearly defined. Now, what is the next question? Discharge. Good. Discharge from the nipple. During the last class, we already discussed the discharge, whether it is from the single side, single breast, or bilateral one. And we have seen the color, how color will lead you, give you some clue for you to the diagnosis. What is the color? Different colors we have discussed it. Serosanguinous, multicolor, blood, all these things we discussed. So next thing we ask is there any discharge from the nipple? Example, I told you, during lactation, when the weaning occurs, the lactation must stop. Okay, must stop. But sometimes it continues in spite of weaning. They are called galactosile. That also we have already discussed. Okay, next question is nipple retraction, retraction of nipple. Again, I told you the importance of nipple retraction. When somebody complains of nipple retraction, the first question you ask is duration. What is the duration? Sometimes at puberty, the nipple areolar complex doesn't develop peri passu with the remaining breast. So the breast mound, it develops, but the nipple is retracted like in the infancy stage. That is called a developmental anomaly that can be corrected by surgery. But that is dwarfed by the importance of recent nipple retraction. I have already informed you the pathogenesis, that is called clinico-pathological correlation of nipple retraction. Now, just tell me, what is the cause for this nipple retraction, pathological cause? I already discussed with you. When we were examining how to clinically approach to a breast, Fibrosis of ducts, that is the answer. A retraction of the nipple, the cause is fibrosis of the ducts. Okay, fibrosis of the ducts. Lactiferous ducts contracts, fibrosis, that causes retraction of the nipple. Again, to repeat, recent retraction is more important than long-standing retraction. And I already discussed a clinical case, which was in fact first time seeing in that long career. That lady, 30 years, 2 kids, one side retracted, and she is not aware of that. She is suffering because of a retraction, recurrent mastitis. Somebody in the other side happened. They are prescribing some antibiotics. She is taking, okay, relief for some time. Again, the infection recurs. Again, antibiotic. Then she approached us. We have corrected. There is a big abscess that we drained, chronic abscess that we drained. We corrected the root cause. She was happy. The surprising thing is, till that year, she is not aware that nipple is retracted. That is the surprising, amazing. Okay, next question. History of trauma. Okay, good. History of trauma. Traumatic necrosis can occur, that rare, but okay. 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 Loss of weight, loss of appetite. Good. Your swelling in the axilla. That's also good. So when there is a breast swelling or swelling in the breast, you must ask the ipsilateral whether there is any swelling patient. Notice, observe. Sometimes, rarely you can observe swelling in the opposite axilla also. That is contralateral spread can occur, though rarely it is all possible. Again, when we are discussing this, I have told you 85% of the breast lymphatics drain into axilla. That means it is most important to examine axilla, all the groups. I told you what are the anatomical groups of lymph nodes, how to examine, some from front, some go from behind the patient and to examine. So axillary examination, clinical examination is most important, whether they are present or not. It is your duty to examine the axilla because simple. 85% of lymphatic drainage from the breast goes to axilla. Next. Lower back pain. Good. Why lower back pain? Why you want to ask? Any dimpling of the skin or the breast? What is the most common site? Metastasis of metastasis. Okay, you want to ask lower back pain? Good. Again, I have already told you how the metastasis from breast reaches the vertebra, most commonly lumbar vertebra, then femur, thoracic vertebra. Any bone virtually it can go, but these are the favored sites of metastasis, bony metastasis. And in fact, the statistics shows more than 70% of the patients dying of breast cancer do have bone metastasis. This is only from the Western statistics. Maybe in India more because our people present late, maybe because of vanity, economical reasons, or medical fertility, far away, not readily available, so many reasons. So that is 70% is the Western statistics. For us, more than maybe 90% when they die. At the time of their death, they have bony metastasis. And second, Baston, we must be capital Baston, okay, he's a scientist. Baston plexus, I told you, no problem. Baston plexus, I told you, it bypasses. Again, recorrecting what we read, this is called clinico-pathological correlation. We are applying theory here, practically. For practice based on a sound theoretical knowledge. And no problem, Batson plexus. So this bypasses, parallels, joins the other three systems of venous. What are the other three venous systems? Caval, portal, and pulmonary. These three systems are, this is another alternative route. Okay, it bypasses joints and parallels. That's how it reaches the vertebra. Commonly it goes to vertebra. I remember I have shown you one bone scan also where every bone is affected. Any bone can be affected, but commonly it prefers some bones. That's nice, good. Any other thing you want to ask? History of respiratory problems. Good. Now, respiratory problems, how the symptoms, you are already read in medicine, they are telling you that just diseases, how a patient present with respiratory problem. Patient cannot say, look doctor, I have a respiratory problem. How they present clinically. Good. Fever, cough, breathlessness. Okay, fever may be there, may not be there, but cough, breathlessness, chest pain. So commonly there will be cough, breathlessness, dyspnea, and there may be chest pain. Fever may be present, may not be present. And again, cough may be with expectorations or a dry cough. Whatever it may be, there will be cough, breathlessness, chest pain. Commonly they present. Good. Now let us see the clue. Now, here a small swelling, painless, somebody said pain, there is no pain, slowly increasing to the present size. This happened over 3 years duration. Okay. No history of rapid increase in size. Is it? There is no discharge, nipple discharge. And already you have mentioned no history of loss of weight or appetite. Good. Now, why should you ask no history whether there is rapid increase in size or not? Basically, it should be recent rapid increase in size. Maybe present 3 years, okay. Maybe for last 2 months, 3 months, it is growing rapidly. What does it mean to us clinically? Good. Carcinoma increases rapid. Good. Now, what happens is, to start with, it may be benign swelling. Now, a benign tumor can turn into malignancy. Okay. One of the clinical manifestations is recent rapid increase in size. You may have other symptoms like maybe pain, secondary changes, ulceration, bleeding, fungus, all these can happen. But common symptom is there is a recent rapid increase in size. And most commonly, these are painless. So a painless, recent rapid increase in size generally denotes malignancy, generally, not invariably, generally denotes a malignancy. Fibroadenoma, fibroadenomas are of longer duration. Okay, that's okay. That's why we said 3 years. But why we ask a recent rapid increase in size? Basically, it is like this. Each person is asked. It is not chatting. I can't say hi, how do you do? It is not chatting. Each person is asked to have some bearing on either diagnosis or therapy or both. We are zeroing on the diagnosis. For that, we are taking all the clues. Okay, not that we have nothing to do with just chatting. It is not chatting. So when there is no history of rapid increase in size, I can clinically exclude that it is a benign tumor. It is not turning into malignancy. That is the inference we got. And there is no discharge. Okay, good. Now, no history of headache. Why we are asking headache is, not that we have headache, we are asking headache is, we are excluding CNS metastasis. Backache, good, we have already seen how it spreads to vertebra. Bony pains, not only back, suppose somebody complains of a shoulder pain, don't think it is some arthritis or orthopedic problem. There could be a malignancy. There could be a metastatic deposit. Okay. Then breathlessness, chest pain, cough, hemoptysis. Commonly, these are the four symptoms by which patients present with respiratory metastasis. It may be pleural, it may be lung, anything can happen. So breathlessness, chest pain, cough, hemoptysis. Then icterus, jaundice. Why we are asking jaundice is to exclude liver metastasis, though rare. Okay, but it is our duty to ask. Seizures, headache and seizures to exclude CNS metastasis. Each question is asked with a specific purpose. Symptomatically, we are excluding. And any other swellings in the same or opposite breast, no. You must ask whether any similar swellings. Don't say same swelling. It is not same swelling. Use correct and most appropriate word, not something coming loose talk. There is no place for loose talk in medicine. Each word you use, it carries some weight. You say no similar swellings in the same or opposite breast. People say same swelling. What same? Is it Xerox or cloning? What is that? It's not cloning, not Xerox. Then say similar swellings. No similar swellings in the same or opposite breast. Now, past and personal history. She's 20 years, so no relevant past history. Family history, no family history of any breast diseases. In her first degree or second degree, you know what is first degree? Pediatrics people will be telling you pedigree, they draw some diagrams. You know what is first degree, what is second degree, all these things. So no history of any breast diseases in the family. Menarche at the age of 13 years age. Why? Why you want to know the menarche? Just for the sake of asking, or do you think it will have some bearing in any breast disease? Good. Early menarche is a risk factor for carcinoma. Good. So basically, okay, because she's only 20 years, we ask for menarche. Early menarche, that is the longer the estrogen period from menarche to menopause, the longer it is. One, all these factors work in combination, not alone. Remember. So longer estrogen activity, uninterrupted by pregnancy and lactation, all these increases cumulative risk, not a single factor. So she's only unmarried, so we'll ask for menarche at 13 years age. Her menstrual cycles are regular. Then she takes mixed diet, no sleep disturbances, urinary and bowel habits or not. Okay, we are not going for obstetric history because she's unmarried. Otherwise, suppose she's a married woman, maybe 30 years. What else you would like to ask in the history? She's a married, having children. Okay, okay. Nulliparity, whether she has children or no children. She has a parous woman. Then lactational history. So whether she breastfed or not, one, any breast biopsy, okay, late marriages, okay, lactated or not, good breastfeeding history, elderly age, radiation exposure, good. Okay, late marriages, rather than late marriage, we say age at the first childbirth. Age at the first childbirth terminated by a full-term pregnancy. We want a full-term pregnancy. That is most important. Basically, they say this is a Western statistics. Okay. Recently, I was really surprised when I see this United Kingdom, England Prime Minister Boris Johnson was blessed with a boy. His age is 52. Oh my God. And I don't know what is his Mrs. age, but his age is 52 at the time of birth of a male child. That happened recently, few months back only it happened. He is none other than the UK British Prime Minister, Boris Johnson. I was really surprised. 52 is having a small kid. That is amazing. We cannot imagine such a scenario here. Anyhow, they passed the golden age. So late marriage, rather good. Late marriage consequently leads to late childbirth. More than 30, theoretically, you increase your risk. Okay. So now, having you read gynec or OPG, and they finished syllabus, okay. Now, what is the ideal age for a first childbirth? You tell. Ideal age, we do not do ideal things, okay. But what is the ideal age? You cannot say SPM you read, okay, 23. Okay, okay, nice. 28, 20, somebody said 28. Oh, they increased. They are going to the risk group. They are going into the risk zone 22, 26, 25. Yes, that's good. Last two answers more are similar, but they are not correct. So we cannot say now you have qualified SPM. What is the life expectancy of females in India? You tell me. Life expectancy of females in India from SPM. 55, that's no too low. 70, somebody said 70. Anyhow, 75 to 80, 72, good. Anyhow, the problem, you remember this, everywhere in the world, be it United States of America, Australia, Europe, Japan, or anywhere, including India, females are better suited biologically to live longer than the males. That is a fundamental point. You go to Japan, there females, they outlive males by almost 7 years on an average. So somehow nature wants females to stay longer than the males. Exact reason, we don't know why it is happening. It is a worldwide phenomenon. I don't know whether SPM people tell you these things or not. I do not know. But this is most important. Why males everywhere, they live shorter duration than compared to females. Either in the developed countries, advanced countries, industrialized countries, or a still developing countries like India. That is really very interesting. Why? That's how nature made us. Okay, it's all right. No. So if you say it is 72, 75, you cannot say my expectancy 75 will have children at 50 years, like Boris Johnson, US, UK Prime Minister. No, there is a ideal age where that age is ideal. Suppose if you don't have children by that age, what you can have after 30, even 35, 40 also. But there is increased risk of other congenital abnormalities like Down syndrome or so many other disturbances can occur. You are increasing the risk chance. That is not the ideal age. Okay. So you should have a children at the ideal age and balance your career and family. Both must be balanced. Simply, you cannot say, I will have MD, after MD, DM, after DM, I will have children. Then you will have children and you will have a patient in your own home, you can treat 24 hours. You have abnormal children who will be engaged fully in practice. So that is not our idea. Balancing your career and family life must be go hand in hand. You pursue your academic activity, nobody says no. But what about your family? After 35, why you want to produce some, increase the risk for defective children? That you think it over. Anyhow, so you cannot say life expectancy is around 80 years, I will have children at 60. No, that is not possible. Okay, so menstrual cycles will only ask because she's not married, we are not going into anything. Urinary bowel habits normal. Now, physical examination, you will ask a patient is conscious, coherent, well oriented to time and space. You may ask why, where are you? She says, I am in the GVP hospital, in the surgery OPD, room number 10. And what is the time and date? She will answer you. You will ask her why you came here. There is a problem. So that is a physical examination. So patient conscious, coherent, well oriented to time and space. Then you moderately nourished, anemic, no cyanosis, jaundice, no jaundice, no clubbing, no pale edema. Young lady, we don't expect any of these things, but we have to examine all these things and to make a note of it. Now coming to the local examination, here it is on the right side the problem. So we are supposed to examine the normal breast, left breast and axilla, at least inspection normal. Examination of the right breast. Both breasts are asymmetrical, not symmetrical, because there is a swelling you can see in the first picture. How you see symmetrical? Symmetrical means mirror image. The best example for symmetry is a butterfly. It will have a body and two wings. You cannot have one wing big and one wing small. Does that butterfly flies? It just crashes. Emergency landing and crashing. So there may be minor asymmetry, but doesn't matter. But they are asymmetrical. There is a lump in the upper outer quadrant of right breast. You can make out. Sometimes in the breast you will not see any swelling or lump in the inspection. Okay, there may not be anything. You cannot make out. Then you have to go for palpation. But here, fortunately, there is a lump you can make out in the upper outer quadrant of right breast. Skin over the swelling is normal. Lump. Now, what is the difference between lump and a swelling? Now, tell me. Difference between lump or swelling. Is there any difference or same or their opposite words? Whatever it may be. You just tell me. Abdomen swelling. Oh God. Abdomen swelling. Lump is what we feel and palpation. Okay, it's all right, no problem. In fact, both are almost synonymous. There's not much difference. But some areas we use certain terms. That is a tradition. Traditionally, we use it. So abdomen, we say lump in the abdomen. Breast, we say we won't see swelling, we say lump. Okay, it's only tradition how it separates. So upper limb we say swelling. We cannot say right upper limb there is a lump. We say there is a swelling. So both are synonymous, but some tradition says you use a particular word at a particular space. It is nothing like hard and fast rule, but it is a traditionally we are using it. So there is not much difference. Lumbar swelling, both are clinical findings. So lump is what we feel palpation, swelling is what we see on inspection. They are not correct, but almost synonymous. Okay, no problem. Why is swelling? Sometimes patient says lump also. Okay, no problem, but I just told you that not much difference. But traditionally, we use a particular term at a particular space. That is traditionally sanctioned. Okay. It is a 2 into 2 centimeters smooth surface, well-defined margins. Nipple areolar complex is normal. There is no other swellings in the breast. On the palpation again, left breast and axilla, normal side. It is normal. Where first? On palpation of a right breast, a lump in the upper outer quadrant, dimensions same. Then we see for local rise of temperature or tenderness. Okay. And you know how to see the local rise of temperature. One, and why it must be seen as the first point in palpation. You know the reasons. Just tell me. The question is, how do you elicit temperature, uh, temperature in a swelling with the back of the palm? Good. Why back of the palm? Why not palm or surface? And why can't we bless the swelling? Go, go. Why can't we do Ayushman Bhava? Why back of the palm? There must be some scientific reason. Not simply back of the hand, thin skin. Okay, good. Any other thing? Good. Palms are thick skinned. Okay, thin skin, thick skinned. Okay, that is almost same. Less fat. Okay, more sensory nerve endings. Okay, okay, nice, good answers. Good. And you can the number of regions, but I tell you one more reason only. When you compare with the palmar surface and dorsal surface, palmar surface is more moist. So thick skin, more sensory nerve endings, less fat, and you have more. This is more moist when you compare the palms with the dorsal. But there are some more reasons, but this is enough for you. Okay, no rise of temperature and no tenderness. Now my question is only part of the question is answered. I said why you see as the first point on palpation. I can see it later. To rule out inflammation. Even if I see at the end, I can still rule out inflammation. I can still rule out mastitis. No. Again, I repeat my question. When you have a lump on palpation, when you are able to make out, the first thing you see is when you have a clear lump. Okay. The first thing you make out, you do is look for the rise in the local rise of temperature by the back of the hand, as you correctly said. And why this must be the first item? Why can't I see it in the later? What is your objection? Why first? I will do it later. I will do it. But at the end of the examination, do you have any scientific objection or scientific rationale? Or simply just do it. Anyhow, no rise in temperature, no tenderness. Why we see tenderness is this is correct to rule out inflammation, to rule out mastitis. Again, smooth surface, well refined, round margins, firm in consistency. Now it is free from the skin. It is mobile within the breast tissue. That swelling is mobile within the breast tissue. This is most important. We have said upper outer quadrant. From there you can push the swelling to the remaining 3 quadrants. You can move it freely. Sometimes it is called breast mouse because of its free mobility. Okay. It is slipping because you just apply pressure, it slips because it is so mobile. Extensively mobile. That is a very important point here. It is not fixed to the pectoral muscle. I have shown you. We already discussed how to contract the pectoral muscles. You ask the ipsilateral arm on the waist and to ask the patient to press it. Check the anterior axillary fold, whether it is taut or not. It is taut means the individual is pressing. Then you examine the muscle lump over the muscle in 2 directions, opposite to the muscle fibers, along the muscle fibers. When it is fixed to pectoral muscle, there will not be any movement along the direction of the muscle fibers. Opposite, you can elicit some mobility and fix it to the chest wall. What is the definition of chest wall? I have already informed you. Serratus anterior, intercostal muscles and ribs. These constitute chest wall and not pectoral muscle. Okay, chest wall anatomically means intercostal muscles, ribs and serratus anterior. 3 constituents in the definition of chest wall. Pectoral muscle is not considered as chest wall. Okay, Nipple areolar complex is normal. No other swellings in the breast and no palpable lymph nodes in the axilla. Good. Whether they are present or not, that is a different issue, but you have to examine thoroughly the axilla, all the group of lymph nodes, which I have told you, lateral, central, apical, subscapular, interpectoral. Then the apical nodes continues with the supraclavicular lymph nodes. Again, supraclavicular lymph nodes either through jugular chain or thoracic duct joins the venous system again. That all we discussed. Okay, that you have to see the lymph nodes in the axilla. Now, examination of the systemic examination, CVS, CNS, respiratory system, abdomen, look for any organomegaly. Mainly we look for hepatomegaly. Never say there is no splenomegaly. Then I was working in Guntur General Hospital long time back. One of the PGs presented a case and he said no hepatomegaly, no splenomegaly. For you, no problem, but postgraduates, when they say they are going to become consultants, specialists, put a big low in both and all. In the initial beginning only, I told you there is no loose stock, at least in the PG level. UG, okay, no problem, because we know what to expect from you. You have a number of subjects to read, prepare. But PG, once you have chosen a specialty, you must concentrate, focus on it 100%. He said, no splenomegaly. I simply asked, good, no splenomegaly. Now tell me, from the primary, that is breast, how the metastasis reach the spleen. That's all. I just ask a simple question. You trace the root. Spleen. Don't say vertebra, bats and all. It doesn't work here. I said, if you lay a road from breast to the either left or right to spleen, it takes 6 months. That means if I were the examiner, I will award you big zero. That's all. That's all, as simple as that. Because you don't have basic concept. And you tell spleen is not enlarged, you look for it, and how it reaches you doesn't know. Simply it by flight, is it flight or courier? How it reaches your spleen? So only you say abdomen, there is no hepatomegaly. Pre-menopausal woman, you see for any ovarian, bilateral ovarian, Kuchenberg tumors, that's what gynec people will tell you. And third thing is look for the ID free fluid, that is SS. But basically we don't expect anything. No organomegaly. Rectal examination you just mentioned, don't worry about that at your level. Then clinical diagnosis, now provisional diagnosis. Summing up, a 20 years unmarried girl presenting with a lump in the right breast, 3 years duration, slowly growing, no recent rapid increase in size, no other symptoms. It is a firm, freely mobile, with a clear-cut margins, nipple areolar complex normal, no axillary lymph nodes, no other systems normal. What is the clinical diagnosis? Fibroadenoma. Okay, good, good. Fibroadenoma, you mentioned the right breast. That's good. Sometime back, I went to Hyderabad as an examiner. That is a big corporate hospital. I went there. And when I asked them diagnosis, they are giving one para as a diagnosis. I said, that is a big corporate hospital. I said, summary is different, diagnosis is different. I didn't ask for summary. Clinical summary. I said, diagnosis. Diagnosis must be sweet, short, and simple. Like you see, Telugu movies title. With a manasicha, nunacho, and that's all. It should be sweet, short, and simple. That's all. You cannot give 5 lines or one para as diagnosis. So it's wrong. That is summary. Okay, fibroadenoma, right breast. Good. And you justify your diagnosis. Why fibroadenoma? Because young woman, no other symptoms, 3 years long duration, really mobile, firm, no axillary lymph nodes. We think of a fibroadenoma. Now, what is fibroadenoma? Define fibroadenoma. From pathology, we go to pathology. Fibroadenoma is a hyperplasia from a single lobule. A single lobule is involved. It is hyperplasia. Commonly, these are all hormone dependent. So 15 to 25 years is the commonest age group. This is the commonest swelling in the breast. 15 to 25, common age group. Maybe it can occur outside of this side. Anything can happen in biological sciences, but common. What is the common mode of presentation? Age group 15 to 25 years. What is the cause? Hyperplasia of the solitary or single lobule of the breast. It produces. Then what is the common size? 2 to 3 centimeters. No other symptoms except it is the lump is present. Okay. That is fibroid. And this fibroadenoma can be classified pathologically into intracanalicular and pericanalicular. Pericanalicular means around the ducts there will be this fibrotic stroma develops. Intracanalicular, within the ducts it develops. But that is what pathology people classify. But clinically it is not important because in any given case, you may have both compounds. So clinically, it makes no sense either pericanalicular or intracanalicular. It makes no sense. Maybe pathology people classify it. It's okay. For not for a surgeon, we don't bother about such minor things. Whatever it may be, where treatment is here. And basically, this is a benign tumor. You have a well-defined capsule. That is the most important. What does it mean? Okay, let it have capsule or no capsule. Capsule means we can enucleate the fibroid. That's important. Open the capsule, enucleate. Well, next question. Now, investigations. We have made this one, investigations. This is a triple assessment. We have clinical assessment. We have completed radiological assessment, either ultrasound or MRI. Tissue diagnosis, FNAC, cytopathological, biopsy, histopathological. Now, we have finished the first step, clinical assessment. Now, going for radiological assessment. Because radiology must be always done before. This is a cycle. If you see this is the order we follow. So, radiological assessment must be done before the tissue diagnosis. Because the tissue diagnosis, if you first do it, may alter the radiological findings or it will make things complicated for us. We cannot assess it radiologically because there is already some interference. Now, radiological assessment coming, clinical assessment, we are taking the patient to radiology department. There are two majority investigations, ultrasound and or MRI. Which one you prefer in this case and why? You have both the modalities available. You have to make a choice. Which one you prefer? Ultrasound. Good. Ultrasound. Ultrasound, ultrasound, ultrasound. Ultrasound to confirm soil. Okay. Here we have not mentioned what this is taken from a standard textbook. In fact, we have another choice also. Ultrasound, mammography, MRI. And mammography is missing here. Okay, no problem. But even if mammography is now you add mammography. You have ultrasound, MRI, mammography, all of the above. Which one you choose now? Good. Depends on the age of the patient. That is again, okay, good. Mammography, ultrasound, because young women have dense breast tissue, young patients, USG. Good. Basically, in this case, depending on the patient means, no, I have already given you 20, 20, 20 is the age. And remember, now, after this exam, you will be preparing for the NEET PG exam. Now, NEET PG exam, most of the times, they don't ask you what is the commonest, what is the least common, like that. They'll give you a clinical scenario and how you proceed. You have to apply your clinical knowledge. Each case. You cannot give generalized statement, if and when, but no, nothing like that. In this particular case, what you will do? Tailor-made, answer to the point. So it depends upon the age of the patient means, already we have given it 20 years. Now which one you prefer? Ultrasound, mammography, MRI? I have already given 20. Okay. So 20 years means young patients, the mammography is not much useful because of the dense breast tissue. So ultrasound is a preferred method of non-invasive diagnosis. Ultrasound, you have to do it. Ultrasound, ultrasound, ultrasound. If there is some problem, then go for MRI. But first and foremost is do an ultrasound which is readily available. And it is non-ionizing radiation. There is no radiation. You can do any number of times. That's why OBC people do ultrasound so regularly in pregnancy. It doesn't harm neither the fetus nor the mother. You do any number of times. But whereas MRI, CT, or mammography, they are associated with radiation. MRI, you can't do it. CT radiation, mammography radiation. There is ultrasound 100% safe, no radiation. Okay. So mammography we don't do because mammography is not much useful in young people because of the high density of the breast tissue. That is the answer. Okay. So ultrasound will do ultrasound most 99.9% you will have the diagnosis. Once you do radiological assessment, then only we are going the tissue diagnosis. See the sequence, clinical assessment, radiological assessment, and tissue diagnosis. You cannot alter this sequence. You cannot say first I will do FNAC. Okay, you do FNAC, then you have a radiological assessment, going to become difficult. This is the order you have to follow. And this is called a triple assessment. This gives a positive predictive value of more than, the book typically says it exceeds 99.9%. So the positive predictive value for triple assessment in a case of breast disease exceeds 99.9%. This is I'm just quoting the book. So confidently say this will do because 20 years I will do ultrasound, ultrasound, ultrasound. Okay, we have a diagnosis. We have confirmed FNAC or biopsy. Mostly we'll do FNAC. Though in the West they do this biopsy means two-cut needle or core needle biopsy, but we'll do FNAC. You know the advantage of FNAC, the limitations, what is the advantage of biopsy, all these things. You know that when I don't know whether breast is covered or not. Maybe, but they'll discuss why, which one you prefer. What is everyone has got, everything has got some advantages, some disadvantages. See, in life it happens, you know, you have to balance. You have to weigh the benefits and disadvantages. Example, suppose somebody gets a headache, simple headache, will take a paracetamol. But paracetamol can produce, you know, acute liver failure. 1 in million. I don't know whether I'm in that million group or one. So we take that 99%, nothing will happen, we'll take a paracetamol. And another common food item which people take very veritably is that mushroom. Though fortunately it is not here, But if you go to some other Western countries, there is poisonous mushrooms which produce acute hepatic failure. And when there is acute hepatic failure, there is no other treatment except you go for liver transplant. But fortunately, it doesn't happen. That species may not be readily available in India. But in West, so many cases reported. Other day, maybe 2 months, 3 months back, I was reading in the Hindu, some 7 people are affected in a tribal area after consuming this poisonous mushroom. It all depends upon your immunity, your comorbid conditions, your age and all. All may not go for permanent hepatic failure, some may recover. So everything you got some advantage, some disadvantage. You have to pros and cons, flip and flap. You have to weigh them. Any drug, no drug is without any side effects. But we believe that it doesn't happen. Most of the times, you by taking a simple paracetamol, your headache will get relieved. We don't think of hepatic failure, liver transplant. No, that we don't do. So anyhow, you do FNAC, cytological or biopsy, core needle biopsy. Now treatment. Now what is the treatment for fibroadenoma? In this case only, what you would like to do? 20 years girl, unmarried. She came. Now what to do? In the West, it is a common practice that when somebody comes to we'll discuss that is called a cafeteria approach. That means you give all the options, okay, and patient makes a choice. You go to canteen, you ask what are the things available, they say so many tiffins and all. You make a choice. Like that, a cafeteria approach, you have to discuss each pros and cons and everything. Okay, now somebody said observation, somebody said excision through circummeral incision under general anesthesia. What is that 6 months interval? I do not remember. You ask her to come after you are in 8th now. You say you come when I was in 9th semester. What is that 6 months interval? Excision. After 6 months interval, no, I do not understand. What is that 6 months interval? Observation done every 6 months. Okay. I thought once you go to next semester, then you ask them to come again. No, okay, it's all right. Now, the treatment is simply like this. Every fibroadenoma doesn't require surgery. Okay, 1. Because simply they come to surgery, OPD, I cannot say I will do surgery for everybody. No. 2. 3. Fibroadenoma requires treatment only when number 1 criteria. The FNAC or the biopsy is suspicious of malignancy. Suspicious. Okay, that's 1. Second, it is rapidly growing. 2. And the third is when the patient desires it must be removed. Generally what happens, somebody maybe content there is some lump in the left breast, no problem. We keep under observation. They may be happy. Some people will continuously worry, constantly worry what will happen when I'm sleeping, will it turn into malignancy or what will happen? All these things worry. So 3 things is cytology or histopathology, suspicious. Okay, the pathologist can't say clearly whether it is benign or some cells showing pleomorphism, all these things, some cells not showing. So suspicious cytology or pathology report, 1, it is growing rapidly. 2, third, when the patient desires. When these 3 criteria is not there, what we'll do is majority they resolve spontaneously, but you need patience. You have a 6 months, 1 year patience to observe it. You hope that it will subside. But if somebody is continuously worrying, anxious, then we have to do it. Okay, we'll do it under general anesthesia only. We'll do it through a cosmetic appropriate. Sometimes you'll have multiple Fibroadenoma in the same side or the opposite side. That also we can do through the same incision. We'll do it. We have seen that enucleation can be done because these are all well encapsulated. Even if you remove them, provided patient is confident enough to come for regular checkup, she knows the risk, she come for compliance, regular checkup, then it's okay. You can observe for some time because they may resolve spontaneous. Okay. Then now, any questions? But most of the people or most of the person, they do not go for observation. At least in our Indian circumstances, they have said, okay, you remove it, send it for histopathology once for all. Let me be assured that it is no malignancy, it is only benign tumor. So most of them prefer this route. So we'll do it under a good cosmetic incision, circummalar incision, where the incision will not be seen. Okay. After surgery and all, we will not see that incision. There is no disfigurement, no scar. So we'll remove it. We'll send it for histopathology. They give a final report. It is only benign. Be thank God. Be happy. There is no problem. Will it? Next question. They will ask you, doctor, will it not recur? Well, that is a difficult question to answer. Generally, it won't recur. Even if it recurs, we have to remove it again. But don't give 100% guarantee that it will not recur. Generally, 98% it won't recur. Sometimes, maybe remaining 10 it may recur. Even it may recur if they come for close follow-up, we can remove it again. There is no problem. Okay. Next question. I'm asking questions because you are not asking. Now, what are the chances of these fibroadenoma turning malignant? That is the next question they ask. Doctor, okay, I will keep it like that observation. But can you give a guarantee that it will not turn into malignancy? What will be your answer? What will tell the patient? She wants to know the malignancy risk. What you say? Can we say 50-50? What we say? Okay, somebody has written observation done every 6 months, less chances for recurrence. Okay, that's so good, nice. But now we are discussing the chances for malignancy. Suppose if you leave it like that, somehow patient is not coming for follow-up. They come after some time. And what do you say now? Uh, Okay, at this age and in this particular case, you can assure that 99.9% there is no chance for turning into malignancy. Whereas half to fibroadenomas which occur in the middle age group, they may mimic sarcomas of breast, but that is again very rare possibility. Here 99.9% it doesn't recur. There is no problem. Provided they can come for regular follow-up, it doesn't. Okay then, we'll close the session. Thank you.